I want to thank DebRA for organizing this. I think that the community involvement here with the patients and the advocates and the physicians is fantastic. Let me get that down. I'm getting a little bit of feedback here. I think, fortunately I'm at the end of this conference this year, so I have a chance to look at what other people have done. And in the 33 years I've been in pediatric dermatology, I've never had as much hope for EB as I have today. I think what you've seen with the physicians who are caring for the patients, with the research, I think we're really starting to move forward. But a couple cautions I would like to do. We have been working on gene transfer for 20 years. I'm going to sort of walk through that. But I'd also like to sort of talk about research and how it affects patients who have such a severe disease. My talk should be about 15 to 20 minutes, so we should have at least 10 minutes at the end for question and answer if you like it. It's important to emphasize that patient research is not patient care. So as we're talking about these new opportunities, these new things that may happen, when we do research, we do a protocol. We have a sequence of events that we need to do. When we do patient care, we're constantly thinking about what's the best thing to do, what are the things I can do, where can I approach it. In research, if we did too much variability in what we're doing, we would not be able to use the knowledge that we're gaining. So it's a big difference between a structured research program and the way we do patient care. And it's important when you do research to try to do it in a structured method so you have knowledge, you gain insight on how to do it better the next time. So I want to really emphasize that when we talk about someone who is in a research study, they are subjects. It's almost like saying you are a number. I mean, that's a crude way to say it. And that's different than being a patient. But we still have the same compassion, we still have the same concern. We've spent months and weeks and years and decades trying to design that research protocol that we're going to use to try to find the safest way. But it's very important to separate those two, because often in a research project, the patient has an understanding that they're going to get benefit when the research may really not give them benefit. It may give benefit to others, but that individual may not develop benefit. So in the last multiple lectures, you've heard a lot about stem cells. So stem cells, when you first heard about it 15, 20 years ago, were embryonic stem cells. We saw examples that when, make sure I hit the right button here, that when these cells get down to the 8-cell layer, you can still take off one of those cells and form a whole new baby from it. A lot of people have moral concerns about this. These are the embryonic stem cells. But there's a lot of research, a lot of things that have been gained and knowledge we have from that. We know that embryonic stem cells, when the babies form, they can make heart, they can make brain, they can make lungs, and then they can make the most important organ in the body, the skin. And so they have all these options. You've heard about iPS cells, inducible pluripotent stem cells. So now we can take a skin cell, we can take a keratinocyte from the skin, we can take a fibroblast from the skin. We can convert that into a stem cell. We then can take that stem cell and make brain, heart, lung, or skin. These are very important new advances, and they're very exciting, but there's some problems. In the skin, we have a process called terminal differentiation. So the stem cells divide, and your skin is packed with stem cells. The older we are, the fewer stem cells we have, but our skin is loaded with stem cells. Every day, your stem cells in the skin divide, and they develop a process called terminal differentiation, and then they go on to form the skin, whether it's the hair, whether it's the sweat glands, but this is a process that occurs. And so if you think of the skin, we basically have stem cells that are in the lower level of the skin, in the region where type 7 collagen is. It's in the region where laminin 332 would be. These are regions of the junctional EB types. These cells multiply. Some of them stay back as stem cells. They amplify, they grow, and eventually they form the barrier of the epidermis. So in most people, the outer 5% of the skin is the most important part of the skin. That's where the barrier is from bacteria. That's where the barrier is from other things. And the diseases that we're talking about the lower portion of the skin that's the most important. Because now we have a weakness. The chain links that should be holding that skin together aren't working as well, and that's a problem. One of the things when we think about all these new therapies, you have to remember the way that we've evolved as humans, the way that organisms have evolved is by mistakes. And when Dr. Paller talked about DNA, the different base pairs, it turns out in each one of your cells, you have about 3 billion base pairs. And it turns out that every time that cell multiplies, 1 out of 1 billion makes a mistake. So every time you have a cell that goes to the next cell, you have 3 new mutations. That mutation could be something that may make us healthier, it may make us fight infection better, or it could be a mutation that causes recessive dystrophic, dominant dystrophic, junctional EB, EB simplex. These are all mutations. So in the process of these cells dividing, there's lots of mutations. So when we're talking about any type of cell therapy, we realize that these cells are making mistakes. One of the advantages of the skin, because there's this process of terminal differentiation, if you have a bad mutation, there's a chance that that cell may just die and fall off. So that may be good. So what happens with these mutations? I want to give a little background about this because it's very important as we approach cell-based therapies. You can have mutations that can cause, a single mutation can cause a change. Oncogenes are an example where a single mutation can change a cell, and then if you have more mutations, you can eventually have a cancer. There are other mutations that are called underactivity or loss of function mutations, and so these are also concerns. In our body, we have what are called tumor suppressor genes. So we have off switches. So if you have cells in your body that are starting to move towards cancer, they're starting to look abnormal, they're starting to behave abnormal, you have a switch. You have these switches in your body that are tumor suppressor genes that will cause that cell to die and will drive that cell to death. But if you have a mutation in this tumor suppressor gene, you have a problem. If you have 2 mutations in a tumor suppressor gene, you've just knocked out that stop switch. So in a lot of things we're doing with cell therapy, we're concerned that we don't give oncogenes, that we're not getting mutations there. We're also very concerned that we're not causing tumor suppressor gene mutations. So one of the big concerns we have with recessive dystrophic epidermolysis bullosa is the formation of squamous cell carcinoma. So how does that happen? Well, it turns out that most of the squamous cell carcinomas that are seen in the world are caused by sun damage. So what happens is you have a cell that has a mutation, so one single mutation. More sun exposure, you get a second mutation. More sun exposure, you get a third or fourth. And eventually you may develop a squamous cell carcinoma. With sun-induced squamous cell carcinomas, they're usually very simply treated. You cut them out, they're gone. The problem you have with epidermolysis bullosa, recessive dystrophic, is you have these cells that are constantly dividing, trying to heal that wound. Whether the wound is a cliff, whether the wound is a seascape, as we saw. So that constant division and 3 mutations in each new cell, you're setting up for chances of having different types of cancers that form. And so that's what drives these cells to eventually develop a squamous cell carcinoma that can be very aggressive and very lethal. And then what happens is you have your normal stem cell. You may have a transient amplifying cell. So this cell shouldn't be a stem cell, but then it makes a mutation. Just like we can take a transient amplifying cell and move it back into an iPS cell and make it into a stem cell, sometimes your body does that. But what we call it is cancer. And once you start to develop these cells that have multiple mutations that then drive it towards cancer, that's a problem. So anytime we talk about cell-based therapy, you're going to see the word skin cancer is our fear. So gene transfer. What are we doing? We've had a 22-year focus at Stanford University on developing gene transfer for epidermolysis bullosa. This has been a mission for us, and it's been a team that's been working together. Basically, what we're trying to do is take an individual cell that's missing a protein, and we want to correct it by inserting in a gene that will then make the correct protein. And we use a virus as a tractor. So you can think of gene transfer as being a virus that infects the DNA. It takes the gene, in this example we'll be talking about is type 7 collagen. It delivers it into the chromosome. It puts it right in there, and not only does it put it there, it turns it on. So it starts to work right away. The question is, where does it go? If it lands on a tumor suppressor gene, if we've just knocked out a tumor suppressor gene, we have to have some concerns, and I'll get into that. So gene transfer is not gene therapy. This is the difference between a patient and a research. So I use the term gene transfer. I have worked for 20 years to use that term and not talk about gene therapy, because until we show it works, it's a research process. It's not a therapy. And it's very important when we work with our patients that we're causing some risk, that they understand the differences there. So what happens with gene transfer? Basically, we take a keratinocyte, and hopefully it's going to be a stem cell, but it turns out that sometimes we end up with transient amplifying cells. We take our virus vector, we infect those cells. We expect about 60% of the cells to become infected. And when they infected, the virus carries the type 7 collagen gene right into the chromosome, and it turns it on. We then grow those cells in a tissue culture, realizing that every time the cell multiplies, we have 3 new mutations in those cells. The other thing to realize is that 95% of our DNA does not make protein. It's only 5% that's making protein. So there's lots of places in the DNA that we don't care if it's mutated or not. There's lots of places in our DNA that your body really isn't using today. And so where the mutation is, so the risk are good for us. If we insert it in a place that affects a liver protein, we don't care. We're making keratinocytes. The liver proteins are turned off into keratinocytes. That makes a difference. So there's lots of advantages we have, but there's some risk. We then grow the cells up in sheets. And here's an example of what it looks like. This top here, this is the tissue culture plate. So there's a layer of about 5 keratinocytes stacked up on top of each other. If you pick it up, I think you can see the edge here, how it looks like. It looks like you're picking up a thin piece of Jell-O. And here we've even picked it up and stretched it. That's about as far as you stretch it. You pull it any further, it's just going to tear apart. So this is like working with a wet piece of tissue paper. So if you've ever seen wet tissue paper, that's like, you can't graft wet tissue paper. What can you do with it? So what we do is we have these little tiny staples, and we staple this to Vaseline gauze. And we have to staple it so we know what's the top and what's the bottom. So we have a way on our staples to color code it to know what's the top and what's the bottom. Then by adding other layers, we now have a thin layer of keratinocytes, which looks like slime. We have it attached to a different set of gauzes, and then we eventually staple that to the wound. That's the process that we're talking about. We're talking about very specific method of culturing the cells, infecting the cells, and then trying to use the cells in a way that we can do this. Now this process has been developed by a company called Genzyme. It's been used for burn therapy for 20 years in the United States. If you have a severe burn, there are ways that they can biopsy your skin, culture your keratinocytes, and then graft them back on. The advantage of this is your own skin. These are your own keratinocytes. The disadvantage of this is these keratinocytes are now making type 7 collagen, which is also an advantage. But we need to make sure, just like Dr. Mei Chen talked about, we need to make sure that we select subjects in the studies that aren't going to react to that collagen. Here's some of the early data we had where we were able to document that in human RDEB skin grown on a mouse, that we're able to demonstrate that we're able to make type 7 collagen in cells that couldn't make it before. You can see how bright these lines are. This graft over here is a different antibody. In the mouse keratinocytes are constantly competing to push off the human keratinocytes. And so we're trying to show here that these are human keratinocytes. These are not mouse keratinocytes, and they're making active human type 7 collagen. This is a study that we've done showing where we can keep the human skin using special techniques. We can keep the human skin on a mouse for over a year. And then by looking at that, we can see that we're still making type 7 collagen here. And it's sort of a spot weld. So when we culture those cells, we may not infect all the stem cells with type 7 collagen. So on this one, you can see we have a spot weld here, we have type 7 collagen here, we have it here, and there may be some spaces in between where it's not there. But we think by spot welding the skin that we may have benefit, that if we can increase at least 50% of the surface area of the basement membrane with active type 7 collagen, we may be in good shape. The other thing we can document is not only is the type 7 collagen there, the anchoring fibrils look totally normal. So we are probably, we're overexpressing the type 7 collagen. We're making more type 7 collagen than would normally be made by those keratinocytes. And we're able to show that the anchoring fibrils really look totally normal. So that's what we want. We want normal type 7 collagen. We want normal anchoring fibrils. So what's some of the preclinical data we have? We've been able to show that our retroviral vector is able to cause expression. We've been able to show that it can last as long as 12 months. We expect on the human, we can only keep skin on the mouse for about 12 months. That's sort of a heroic effort. On the human, we expect it to last for the life of the individual. We were able to show what's called ex vivo. That means we infect the cells in culture. We don't infect the cells in humans. And we have FDA approval. The Food and Drug Administration has approved our trial. We have a go. We've had this go for about 2 years. And when Mark D'Souza talked about the protein therapy, I mean, working through the FDA, this has been a long process for us. We went for FDA approval for junctional EB in 2000, and we were getting ready to go forward with that. But suddenly there was multiple problems that happened with gene therapy and gene transfer, and we decided at that time to stop that process, and then that's where we moved into type 7 collagen. And so this has been a long process to get the FDA approval, but we are there. Since the FDA approval, we have other complications that occurred, but we're moving forward. We're hopeful to graft within this year, within 2012, our first subjects. The FDA rules are for us are the same as they're going to be for others. In a disease that affects adults and children, you have to start with people over 18. The reason for that is in our society and our laws, we believe that over 18 is an age when people can make their own decision, that they're not being forced by their parents to make the decision. So that's how the trials are set up. What are the requirements the FDA has for us? What are the protocols that we expect? What we expect to have is at 12 weeks, we expect to see expression of excellent type 7 collagen. The same at 6 months, and we'll be looking at that by immunofluorescence. You've seen a lot of immunofluorescence slides over the last 2 days. And we expect to see restoration of the anchoring fibrils. After we've completed the first 5 adult subjects, the FDA will allow us to present back to them and reevaluate, and at that time they may let us start to move down into children. If you move down into children, you'd also, between the ages of 7 and 17, you'd have to have assent, meaning the child would also have to agree to allow this to happen. So if you go into the doctor's office and your child is 10 and they're going to get immunization and they say no, unless they're really bigger than the doctors and the nurses, they get their immunization. In our trial, if the 10-year-old says no, we say you're the boss. No matter how many iPods your family may offer you, and how many computers, we're not going to do it. So what are the long-term side effects? I mentioned the mutation rate in cells to make sure you understand that. So one of the concerns we have is depending on where this retroviral vector inserts into these cells, and we expect to have our goal and the requirements the FDA has, on average, we're going to have about 3 vectors, three sites of infection in each cell. So we're going to have 3 times the normal production, at least, of type 7 collagen in each one of these cells. People who have recessive dystrophic EBs, patients with that, some of them make most of the proteins associated with type 7 collagen. We don't expect those patients to have an immune response to it. We don't know. And this is what the protein therapy will be looking at also. So we expect not to see autoimmunity. We don't expect to see patients attacking this new protein. And the experiences in other protein therapies, we don't expect to see the autoimmunity. If we do see it, there are ways we can approach it. There's ways we can work at it. And the FDA is totally aware of that. Initially, we will not be using ways to cut down immune response, but they're aware that if we need to, those options in the future may happen. And again, we have a protocol that says what we can do and a protocol that says what we can't do, which is different than patient care. Toxicity, we don't expect to see any toxicity with our viral vector. We have grafted and treated, wouldn't be treated, mice wouldn't consider treated. We have grafted at least probably 200 mice that have been exposed to our viral vector. We've never seen the vector move out of the skin. We've never seen it in the other organs. We still have more studies that the FDA is requiring for us to do as we go forward with our trial. So we're really trying to look at to make sure that there's no toxicity, that we understand all the risks. And if it works, the hope is we can graft larger areas. And if it works, we hope we can graft infants or newborn infants. That's the ones we want to get to. We would like to be able to graft normal keratinocytes expressing type 7 collagen to blisters on newborn infants so we can prevent the scars, we can prevent the fusion, the fingers. Those are the things that we're after. That's the goal we have. So why are these things moving forward? Why do we see so much research moving forward in Epidermolysis bullosa in the last 20 years? Why has this meeting been so exciting? And the reason is the skin is easily accessible. The FDA will allow us to do things in the skin they won't allow us to do in the liver or the kidney or the heart. So these are great advantages. And so to work with a skin disease, if we have a mistake, we can hopefully see it early and we can cut it out. And so those are the things that we're trying to do. So there's a big advantage, and that's why you're seeing a lot of interest now in recessive dystrophic EB and junctional EB and all types of EB. There's currently about 300 skin diseases genetically that we know of. We think there's at least 500 genetic skin diseases. So success in one of these diseases can have benefit in other diseases. You've heard about the iPS cells. These may have major advantages. And again, this iPS cells goes through hundreds and hundreds of cell divisions to get back to where you have as a mesenchymal stem cell or as a keratinocyte. And each of those divisions has a risk that you may get another mutation. So applying the iPS cells to the skin, we think will be a much safer way than giving it as a mesenchymal stem cell, infusing it other ways. So these are all different things. And correction of the iPS cells can offer a lot of other advantages. So currently we have what's called an IND, an investigational new drug. This is a major hurdle to get through for the FDA. Our ultimate goal is to make this be a drug where everybody could have access to it. And that's where we're trying to move forward. But realize the Federal Food and Drug Administration in the United States has not yet approved a human gene therapy product for sale. So I'm not talking about gene transfer. Now we're talking about gene therapy. That means something that works. There's nothing approved in the United States. There may be a drug soon approved in Europe. There was a drug approved in China in 2004, not for EB, not for skin diseases, but none has ever been approved in the United States. So what do we do? What's the process? I mentioned protocols. We have very detailed protocols. The information we've given to the FDA is double-sided, about this thick. And these are the rules and regulations they have for us. These are the rules and regulations we have in our study. No unnecessary risk for research subjects. Extremely important. They look at us. You know, do we meet all the requirements that the FDA has as far as investigators? We have to be committed to do informed consent. It takes me about an hour and a half to go through an informed consent with a patient. It's 20, 25, 30 pages. We mail it ahead of time. We have people look at it. And we make sure that every detail of what's written there is clearly understood. It's a pain for the patient. It's important, though, because we need to make sure we understand exactly the rules. And then we have several different review boards that are overseeing us. And we need to adhere to the regulations. And that, again, is why a clinical trial is different than patient care. Patient care, you do the best thing you can. Clinical trial, you're trying to do the best thing you can, but you do it in a protocol, and you hope the protocol is accurate. Successful molecular therapy for EB, dystrophic, for junctional, may lead to other forms of therapy. And so this is why, to me, this meeting is so exciting for all the things you're hearing about. The ultimate 20 years from now may be a combination of multiple different methods. We as is many others, are constantly recruiting patients we're trying to identify the patients across the United States. We're trying to start to collaborate with patients across the world, and these are all things that are very important to us. Acknowledgement is extremely important. The patient support groups like DebRA are extremely important. Epidermolysis Bullosa Medical Research Foundation had a vision 22 years ago that gene transfer may be helpful, and for over 20 years they've been supporting our research. And for many years they were the only ones, but for many years we've had other support from the NIH, from the California Institute of Regenerative Medicine. We have a massive grant from them. The Jackson Gabriel Silver Foundation, the New Foundation, very helpful. And DebRA. All these things are important. All these things build community. The scientists talk to each other, the patients talk to each other, and forming that village is going to help us move forward. I'd like to acknowledge also members of our team. You can see I'm not the tallest one in our group. People ask if gene therapy at Stanford, you have to be over 6'4". No, you don't have to be. That's why the other people are sitting down. But we have worked together. Paul Kavari and Pete Marinkovich and I have been together since about 1992. And we've been focused on this process, and we're trying to move forward with it. Many more. So we've gotten a whole institution that's interested in epidermolysis bullosa. We've emphasized the importance of the skin. Last year, I decided to have a party at our house of everybody, our hematologists, our oncologists, everybody who's helping us with EB. And there were about 85 people on that list to invite. That's the village we like. Any questions? I'm happy to answer any questions.
Go back to the slide phone number.
Oh, yeah, call. Yeah, talk. Yeah, email Emily. Don't email me. Emily's right back there. Emily knows about all the patients. But I think, do we have time for questions?
Yeah, we have time for one or two questions.
I was just wondering what the timeline is as far as starting the trial.
Okay. The question is, what's the timeline as far as starting trials? So in 1999, I made a statement that within 2 years or 3 years, we're going to be grafting patients with junctional EB. Little did I know all the side effects that were going to happen over the next 6 months. So the timeline is very soon. My goal is within 2012. That would be the first subject. There's a lot of requirements the Food and Drug Administration has on the first subject before we can move to the second or third or fourth. But I'm hopeful that within a couple of years we'll be starting to move down to children, and we've documented some safety and moving forward. Our timeline is, it should have been yesterday, it should have been 10 years ago, but too many times we've seen too many roadblocks that we've had to work our way over.
Any other questions?
Yes. You're allowed more than one.
So do you expect, do you expect it to,
You want to hear your question.
Do you expect it to, like, would you have to graft every spot on the skin, or would you expect these cells to, like, expand and cover places that hadn't necessarily been grafted?
Okay. So you saw our grafts. Our grafts are about 50 square centimeters each. The FDA will allow us to graft 6 grafts. 5 of those grafts will be on wounds that may have been there for years. We don't know if you can even heal a wound that's been there for years. But they've also allowed us to induce a wound, and our subjects understand that. You know, many of our patients, I'll say, can you induce a wound? They say, yeah, how big you want it to be and how soon you want it. And so those are the wounds that are going to have the better chance of the grafts taking, so those will give us information also. There is a gene therapy trial for junctional EB that was done in Europe in 2006, and it looked like in that the grafts stay exactly where they are. We would prefer that the grafts stayed exactly where they are. We don't want them to start to migrate across the skin. We're hopeful that a graft in the middle of a large wound will migrate into that area, and we think that that may happen. But these are part of the protocol that we'll be watching very carefully.
Thank you, Dr. Lee. I wish we could.